I just want to add my own thanks to those of Stanley for you all coming along today and for all the organisation that's gone into this afternoon's session. My task really is just to give you a very brief history of EMMS and EMMS International as we now are today. As Stanley said, we began back in 1841, but we see this year of anniversary, 175th anniversary, as a year to honour the past, to live in the present and to dream about the future. So hopefully we'll have an opportunity to do that today. As Stanley said, we began as the Edinburgh Association for Sending Medical Aid back in 1841, and out with China, this was the first medical missionary society in the world. And if you fast forward through to 2002, through various metamorphoses, the work had expanded so much that it was necessary to split the society into two charities to carry on the work. EMMS International, of whom I'm the Chief Executive of, and EMMS Nazareth, which is now the Nazareth Trust, running the Nazareth Hospital. So in the early days, the society set out two primary objectives. Firstly, to train physicians to become medical missionaries, and secondly, to change the Church's view of medical mission and the importance that it had as a missionary task. The context I find quite interesting, because if you think about, there was a huge amount of debate in the church back then about whether there was a missionary mandate, whether we should be going overseas and sharing the gospel. And if you fast forward today, the arguments we have about are what responsibilities do we have around aid and supporting people in developing countries. It's kind of the same arguments 175 years later, just a slightly different context. So the society used Matthew 10, 7 and 8 as the biblical basis for what it did, and that, just to remind you, is go and announce to them that the kingdom of heaven is near, heal the sick, raise the dead, cure those with leprosy, and cast out demons. Give as freely as you have received. And I feel there are key words within these verses that really speak to the core of what EMMS International's vision, mission and values are today. Announce reflects the practical proclamation of the gospel. Heal and care speaks directly to the holistic approach that we adopt in caring for others, and give correlates directly to the love and compassion that we want to share with others. So I think there's a real line of sight between what was set out 175 years ago and today. So to meet these goals, EMMS pursued several different approaches to medical missions. In the early days, it funded special lectures, I guess conversations like we're having today, on the topic of medical missionaries and how that's a valid form of mission in serving people in need. They awarded prizes for the best written essays on medical subjects. And then in 1851, they began to fund the training of people to study as doctors to become missionaries. And that led to the establishment of the Cowgate Medical Missionary Dispensary down in the Grassmarket, which was set up primarily to serve the Irish poor, as they were in Edinburgh in those days. And actually, if you took what they ended up doing there and put it in one of the modern-day log frames that we use, you would have very much the kind of projects that we're doing in Malawi, India, and Nepal today. So, EMMS expanded from its UK base in the 1850s once the doctors began to be trained, and the members went on to found several dispensaries and institutions across the world. It's amazing, actually, to look at where all the missionaries have actually gone. Firstly, they went to India. The first graduate went to Chennai, Madras as it was in those days. But quickly the work spread to the Middle East, Africa, and by the end of the 19th century. And over the first 90 years, from the 1850s through to the outbreak of the Second World War, EMMS trained 440 doctors to serve across the world. And all of them went out with almost to a man and woman with UK mission agencies. So the value of medical mission again came to the fore in 1910, as everyone knows, the missionary conference as there was in Edinburgh then. But interestingly, again, medicine was excluded from the conversations, so EMMS felt quite strongly, along with its sister organisation, the London Missionary Society, that not enough attention was being paid to this important aspect of admission. So they organised a parallel series of discussions, at the end of which they declared the following, and I'm going to quote this because it's quite important. Medical missions should be recognised as an integral and essential part of missionary work of the Christian Church, because we are led by the example and command of Christ to make use of the ministry of healing as a means of revealing God to man. And secondly, because of the efficacy and necessity of such work as an evangelistic agency, having been proved in many lands again and again. and as such has been sealed by the blessing of God. Now, to our knowledge, this was the first ever mention of integral mission by anyone, which, we've had a look and we've spoken to colleagues here, and it seems that, again, 100 years ago, EMMS was at the forefront of thinking about what healthcare mission was about. So right from the beginning, the Society and later EMMS International have been responding to the changing health needs of the world and seeking to engage the church in mission in its widest form. We've trained healthcare workers, encouraged support from the church, shared information and learning about our work, and developed health services that meet the holistic needs of the people and communities that we seek to serve. And all of this is based on the core of our Christian faith. And we do seek to maximise the impact of our Christian faith as we exercise this through the motivation and principles that we adopt. And we also marry this with the best in secular programme delivery, and also ensuring that we respect the various conventions that are on human rights. So we very much try to match the secular with the faith-based nature of our work. And we continue to increase access to healthcare and improved health for most vulnerable and marginalised people, whether that marginalisation is through low income, social standing, disability, lack of access to resources or other distressing circumstances. And we do seek very much to ensure that everything is sustainable and integrated within the local and national health systems. So in all we do, we seek to honour God and to reduce health inequality, and we are blessed to have such a rich history, and we continue to innovate 175 years later in responding to the needs across the world. So I do believe quite strongly that this year is an opportunity to give thanks to God for the many women and men that he has used over the last 175 years, and that have taken us to where we are today. We want to give thanks for their faith, for their passion and compassion, and the vision that they had. And that vision is still as relevant today as it was 175 years ago. We very much went against the prevailing worldview that mission was something that should be taking place, and we continue to go against many of the prevailing worldviews about how we should reach out to our brothers and sisters across the world. But ultimately, we're here to reach out in love and service and to share the good news of the gospel across the world. And I think it's sad that the world has changed really so little in the 175 years. I think that actually we live in a world that is more divided, unequal and fallen than it was even 175 years ago. So it is really important that we continue to reach out to those people that are suffering from poverty or being marginalised in whatever way. So we act with and on behalf of the church. We inform the church and we're sustained by the church. We walk alongside people in the darkness of the valley. And I believe very much that we are movers of the people of God, his instruments in the place that he has placed us. And we're here to serve God's purposes in our generation. So as it says in Micah 6:8, and I'm going to use the Message translation because I really like it. He's already made it plain how we are to live, what to do, what God is looking for in men and in women. It's quite simple. Do what is fair and just to your neighbour. Be compassionate and loyal in your love. And don't take yourself too seriously. Take God seriously. So past, present and future, we do seek to do justice, to love mercy and to walk humbly with our God. So with that, I'll hand over to my colleagues.
I am glad to bring you congratulations from the German Institute for Medical Mission. DIFÄM is the German name, Deutsches Institut für Ärztliche Mission. From DIFÄM, your sister organization. DIFÄM looks back to a history of 110 years only. So EMMS is our older sister and much more experienced, of course. Nevertheless, I think it was mostly over the past 60 to 70 years that the approach of medical mission has been challenged to adapt to changing global context. So what I will share with you today is a kind of reflection on our history, which I hope will at least to some degree match your own view of the history of medical mission in general and EMMS in particular. So how it began. The healing ministry of the church is based, as we all know, on the command of Jesus to preach and to heal. Over the first centuries, Healing and caring for the sick was a prominent feature of the young Christian church. However, later in history, the church mostly focused on the ministry to preach and neglected the healing ministry. Only in the 19th century, the mission societies gave the healing ministry of the churches a new importance, as they felt the duty to make medical care available in the countries they were operating in. This was the beginning of the time of the pioneers. An increasing number of pious and highly committed nurses and physicians of the global north went to overseas countries to help sick people. Albert Weitzer is one person whom everybody in Germany knows. He is one of the great pioneers. Our founder, Paul Lechler, characterized the medical missionary as the Good Samaritan who takes care of the victim instead of neglecting him. At that time, medical work and evangelization overlapped to a large extent. Medical mission became the heavy artillery of the missionary army, as Herbert Lancaster said in 1900 when he was the secretary of the medical committee of the Church Mission Society, London. Medical mission up to the beginning of the 20th century was an answer to the suffering of human beings, as well as a vehicle for evangelization. Christian medical mission services were mainly curative and institution-based. They became an essential and absolutely indispensable element of the healthcare sector in many regions of the world. During this era of the pioneers, there was no need at all for Christian health services to reflect the reasons for their existence and their approach. Everybody just appreciated their great work. But as we all know, times and contexts have changed. The era of the pioneers was limited. Church health services were challenged to move from having a pioneering role to being partners. So in the following, I will talk about partnership in a double sense. First, I will talk about the partnership between Christian health services and governmental and non-faith-based private health providers. Second, and very briefly, I will have a look at the partnership between Christian health services provided by mission societies and their local partners, local implementers, the latter being mainly partnership between Christian organizations like EMMS and DIFÄM in the north and our partners in the global south. So I will show you one example. It's a fictional example, but may show you how the situation of Christian health services changed over the past 2 centuries. So let's have a look at Milo district in Tanzania. In 1850, no health services at all in this district. Then Christian health services were established, a dispensary in the compound of the mission, and sometimes also a school was founded. So a dispensary or health center was established with a small catchment area of 20,000 people. Let's go to the 20th century. Church health services expanded, catchment area of 50,000. Later, 75,000 catchment area, a hospital was founded in Milo. And let's go to the middle of the 20th century. This was kind of peak of medical mission services. So everybody could look at this picture and say, we are great. We are providing services where nobody else provides any medical services. That was the situation. But then, mainly after some countries gained independence, the countries catched up and the governments improved their health services, benefited the people. So the catchment was enlarged to 250,000, 1970. Later in history, the private health services. So you see the Christian health services don't have a monopoly anymore, but there are others providing health care. And what about the future? Is it that in 2025 all people have access to health services, but Christian health services are not anymore needed? Is that the picture of the future? It's just, as I said, it's fictional, but just to show you that today Christian health services do no longer have a monopoly, but find themselves in a competitive situation. Of course, there are still quotes saying that in countries of sub-Saharan Africa, Christian health services provide between 30 and 70% of all health services. But these are estimates which are not based on strong data. But anyway, my point is not to discuss the current or future quantity of health services, but I will rather look at the quality of Christian health services. So the question is, what is special about Christian health services? What is their added value, which makes them indispensable today and in the decades to come? Only if we know about the identity of Christian health services can we make statements about them as important partners of governmental and private health providers. So the questions about the identity and the specific role of Christian health services are not at all new. They have been an issue since the middle of the 20th century. And as the answers given to these questions decades ago are still of relevance for Christian health services today, I will go into some detail. So let's go back to the middle of the 20th century. After the Second World War, Christian health services in the global South were challenged in a double way. First, in some of the newly independent nations, the governments were ready to take over church health services, a good development. Second, the question was raised whether church health services, which mainly were facility-based and curative, really helped the poor and tackled the root causes of diseases in resource-limited settings. Questions that came up around 1950. During the 1950s and 60s, these challenges were so strong and pressing that many people and mission organizations were not sure anymore if medical mission had a reason for its further existence at all. In the process of affirming the Christian healing ministry at that time, and in the process of articulating the identity of Christian health services and developing new concepts for their practice, the Christian Medical Commission of the World Council of Churches played a crucial role. And I'm mentioning this as DIFÄM at that time had a close working relationship with the Christian Medical Commission of the World Council of Churches, so this is also part of our history. So as I said, the Christian Medical Commission tried to find an answer to the question, what is the identity of Christian health services? What is the reason for their further existence? And as a result of worldwide discussions, the Christian Medical Commission offered a new definition of health, which has been the basis for Christian health services until today. So the definition says health is a dynamic state of well-being of the individual and the society, of physical, mental, spiritual, economic, political, and social well-being. you may easily recognize that it is based on the well-known WHO definition of health, but this Christian definition of health complements the WHO definition with the notion of spiritual, economic, and political well-being. Moreover, health is seen as a dynamic state, and health is not only individual well-being, but it includes society. Now, what makes Christian health services unique according to this definition of health? What is the added value they can bring into partnership relations? So with regard to the individual, Christian health services, as they include the spiritual and social dimension, Christian health services offer holistic care, including the spiritual and social dimension of health. The whole person is taken care of with love and compassion. This is an added value of Christian health services. With regard to public health, if, as this definition states, economic and political factors have an impact on health, health is not only and not primarily a medical issue, but health is mainly a matter of justice. This knowledge that health is a multidimensional issue and is influenced by economic factors very much provided the basis for the concept of primary health care that was commended by the WHO in 1978. Primary health care is based on the conviction that any sustainable improvement of health calls for a comprehensive intersectoral approach targeting at poverty reduction, education, nutrition, hygiene, and the like. The determinants of health must be tackled if health has to be improved in a sustainable way. The curative approach to health is necessary, of course. We need the hospitals, but this institution-based curative approach must be complemented by preventive and promotive approaches. Primary health care is based on the values, on the Christian values of justice and solidarity, and calls for this comprehensive, people-centered and bottom-up approach to health, including the communities, the people at local level. Health has to be improved where people live and where people work. The concept of primary health care, which the WHO commended for all the member states in 1978, offered, and I think we should see that in retrospect, it offered a huge chance for the churches to become partners of governments towards improving health in a sustainable way, as the churches can rely on huge numbers of motivated people, and they have a network reaching out to the most remote regions. So all these factors I mentioned that are added values can be traced back to this very comprehensive definition of health given by the Christian Medical Commission. But of course there is another feature of church health services that can make a specific contribution to health, namely their biblical mandate to opt for the poor, the marginalized, and the neglected. Health is a justice issue. So one should find, and also one finds, Christian health services dedicated to, for example, HIV-positive people or people with mental disorders. And in this line, if I may have a look at the presence also, in this line it is great that EMMS has put a focus on palliative care in Malawi and in other countries, as these people are neglected in our times. And These areas, palliative care, mental health, these are areas where the government is not taking care of. So today, there are many treatment gaps with regard to marginalized human beings and neglected diseases, which Christian health services might fill as part of their biblical mandate to opt for the poor and marginalized. So, compassionate care, community-based health services being based on the values of justice and solidarity, the option for the poor, standing in the gaps. These are all factors, I think, that may well qualify Christian health services to be partners of other health providers, so they can bring in a missing piece. But as an other aspect, I would also like to mention some requirements for being qualified as a partner. And these are areas where church health services have not been so good in the past. So the requirements for being appreciated as partners, because every partnership has to be a win-win situation, church health services have to be ready to become partners. So that was not always the case in the past. So they have to be ready to become partners instead of just working alone and in isolation. And partners have to be reliable in the sense that they offer quality care and that they have strong financing mechanism and a good human resource and data management. So that was not always the case in the past and is not the case so far. These issues are huge problems for many Christian health services. Now I talked about the added value, the requirements for being a partner. Let me also now have a look at how far this partnership has become a reality up to now. As far as I can see, Christian health services have been always very good in offering compassionate care, and that is why many patients still opt for Christian health services if they can afford them. But the concept of primary health care has not shaped the work of medical mission to a larger degree so far. Many mission hospitals still favor, up to today, a mainly curative approach. And also many of them still stick to offering all services instead of concentrating on the gaps and looking for niches where they can offer what others cannot, like the palliative care. Therefore, as far as I can see, there is still room for improvement. Some people go so far to say that Christian health services disappeared off the policy and evidence map. So partnership is not implemented so far. In 2002, World Bank President James Wolfensohn said, half the work in education and health in sub-Saharan Africa is done by the church, but they don't talk to each other and they don't talk to us. So they still work in isolation. Another indicator for a lack of partnership up to today is the fact that the Millennium Development Goals were set up and implemented without considerable cooperation of the governments with the church health services. So the question is, how will that be with regard to the Sustainable Development Goals? I think we will hear about that a bit later. That is what I wanted to share with you about church health services becoming partners of governmental and private health services in the countries of the South, but also here in our northern countries. So for time reasons, I will only very briefly talk about the second aspect of partnership I was mentioning, which is the partnership between Christian organizations involved in global health work and local implementers. For a long time, the pioneers, like medical missionaries, were the Good Samaritans who were medical all-rounders. They were irreplaceable and had no time to pass on their knowledge to their local counterparts as they worked tirelessly from morning to night. They had a dominant role, which of course some of them were not really ready to give up. But what about the sustainability of such pioneering work, the work of individuals who work in isolation and do a great job, but what about the sustainability of their work? So the cartoons I will show you here, they are more than 50 years old, but I like to use them as I see that the insights gained more than half a decade ago, they haven't shaped our work until today. So that is, I think, a cartoon from 1960 talking about taking care of others encourages dependency and loss of freedom. It's good work, but not sustainable. So the other way, the community decides on its own. We are partners, and this approach encourages decision-making and leadership from within the community. So the questions are, is our relationship with our partners really a relationship at equal terms? After being on the receiving end of help for ages, do the local people own the projects implemented in their communities, or are they still doing what we think is good for them? Is what we do still considered an act of charity, or are we moving towards justice and equity? Sustainable solutions call for an approach where the local people are in the driving seat. They are partner at equal terms. And another question, just putting questions now, how far have we come on this continuum of participation from a dominant role to empowerment? How far have we managed to empower our local partners? So these are just questions related to this second aspect of partnership between DIFÄM and EMMS and the partners in the Global South. But I think only if we empower our partners in the Global South so that they are the agents of change, they will be in the position to become appreciated partners of governments and other health providers in their respective countries. So it's about capacity building, empowerment of local people, of local churches and Christian health providers so that they can become partners of the governments in Malawi, India, and so on. So I really hope that church health services all over the world will move from being pioneers to partners, as they truly have a lot to bring into partnership relations, which others do not have. But only if Christian health services are shaped by what makes them unique and specific, they will have a future. I'm convinced only then they will have a future and can be partners in a joint endeavor for a better world. So only if they bring in the missing piece, their added value, then they will be partners for a better world. Thank you for listening.
So just for those who may not be so familiar, the Sustainable Development Goals, they followed from the Millennium Development Goals. The Millennium Development Goals were 8 very particular goals, which were placed on mostly low and middle income countries, targets with which to try and improve health, education, water, sanitation, partnership. And many of the goals weren't actually met, but they run from 2000 to 2015. End of 2015, these new goals, the Sustainable Development Goals, come into being 17 goals with 169 targets, really about ending extreme poverty, fighting inequality and injustice, and protecting the planet. And the 17 goals, there's only one of them, goal 3, which you can't really see it, that's directed particularly towards health. Now, what am I doing wrong that's not changing? Is it the... It's now sort of... You're going to watch the goals for quite some time, and I'll tell you. No, it's the other way, if possible. Thank you so much. So we'll try this one. Okay. So these goals, though, have easy way to remember them is around 5 categories, all beginning with P. People. A lot of these 17 goals are really about how do we change the way that the world has dealt with the people of the world, the humanity of the world, because poverty and hunger are the most dominating features of the majority of the world today, and how we can, in our 21st century, still live in a world where people go to, sleep hungry is obscene in a world that's got so much of extraordinary advancement in every other form of technology. It's about the planet, how we protect the planet from degradation, and how we change the way that we actually use the resources of the world and manage the resources differently. Because there's a very strong message now, particularly coming out of a Planetary Health Alliance movement, that the world's resources are actually no longer able to sustain the population of the world if we continue to abuse the resources the way we're doing, if we continue to force, extract energy the way we're doing, use energy, if we continue to, where we're going to, with climate change, be more and more destructive with the atmosphere, if we continue to use and abuse water the way that we're doing, if we continue to mine rare earth, if we're doing these things, are meaning that our planet can no longer sustain our population. The prosperity is about, again, how do we ensure that people have access to an advantage of, and in a just way, the economic, social, and technological progress that is part of so many countries and not part of so many others. Then a very strong message around peace, because unless we have joint and inclusive societies, internally and externally, and our world doesn't need to hear this message around peace, given what's happening, as you all are so aware, with the Middle East. There's just about hundreds of wars going on at the minute. There's the wars that we hear about in the media. There's the wars that we don't hear about. There's the wars that we've heard about sometime in the past that have just gone into insignificance again. No one's interested again at the Central African Republic. It moves up, it moves down. There are so many places, and yet we know that peace is missing, and partnership. And you can see why I'm emphasizing this, because each of you will recognize and think, this is a fundamental part of where the Christian faith actually has a contribution to make. Now, the language of the Sustainable Development Goals are quite extraordinary, because it's the first time we find in the language in the preface to the Sustainable Development Goals that was developed by the United Nations, a language that's effectively redemptive language, a language that uses a theological proposition and a premise. The language talks about the healing of the nations. It talks, and you've mentioned the preferentials of the poor, preferential options for the poor, and that's very much from liberation theology, something that Paul Farmer, something that Jim Kim, as head of the World Bank, has pushed again and again. We need to rethink what we're doing, but something that EMMS effectively over 100 years ago was identifying. We need to understand what are the options for the poor that we're leaving no one behind. In this language, is a change. But a world where we really have to push forward the preferential options for the poor is quite a tragic world. A world where you think our humanity, what has happened, that we're moving, we have to state what is fundamental to all of us, the equality of humanity. But that has to be emphasized again in the United Nations documents. So, as I said at the beginning, this is an extraordinary time for faith communities, particularly church communities, because faith's on the agenda. And it's on because these SDGs are now moving into almost like a theology or a concept of care that wasn't part of the Millennium Development Goals. And I should have said around the Sustainable Development Goals, these goals are not just for low and income countries, they're for every country. Every nation that signed up to these goals, every nation that belongs to the United Nations grouping, these goals are for them. So Scotland has a Sustainable Development Goals strategy, as well as Malawi. We are in much more of a community. But there is in the goals this push towards this agenda for healing and wellness, a recognition the old system doesn't work. Reflecting on what you're saying, a very strong message around partnership. And an understanding that we've talked about infectious disease pandemics. We're very conscious of the non-communicable disease pandemic, and non-communicable diseases are stroke and heart attacks and COPD and cancers and mental illnesses. But there's also this recognition now that what's driving that particularly the non-communicable disease pandemic, and we used to think those are luxury diseases of high-income countries, those types of diseases, whereas the diseases of Africa are malaria, TB, HIV. It's not the case. The diseases of Africa, many African countries, are these non-communicable diseases. But the drivers of non-communicable diseases are actually also the drivers of economies. They're the tobacco, they're the sugar, they're the alcohol. And these drivers are also creating almost like a pandemic of nihilism that's in the world today. It's a pandemic that's not being recognised, other than the fact that our global burden of disease statements and standards identify mental illness as one of the major destroyers of human health in the world, right across every country. So if you can take from that understanding of where that the Sustainable Development Goals, which are really structuring how we move forward, if you can understand there in them is this sense that actually what faith communities have, what the church has, is something different. It's something that touches to the very heart of the need that societies, the need that humanity is expressing. And last year at the World Bank, at a conference I was privileged to attend in July, the World Bank president, Jim Kim, said, we need prophetic voices to inspire us and to evidence to lead the way. And this conference was around the role of religion, the role of faith communities in contributing to development. And at the conference, he spoke quite emotionally almost of how destructive the bank had been in the past in its responsiveness, in its attitudes, in its failure to listen to those peoples who were actually leading and changing the way that communities were working. Because he recognised very publicly that it was the churches, the church health associations in many African countries, faith communities that had made the biggest difference to health. But because, and I say this as an academic, and an academic who sometimes goes to bed frightened, will we, as academics, push forward words and words and words and publishing papers and pushing forward strategies and ideas and yet not actually do action? The reason why the church's actions haven't been placed into the WHO as strong, haven't been placed into the UN, haven't been placed into many public domains and research journals, etc., is because the people who were doing them, the churches, the communities, EMMS, the societies, were actually getting on with the work. They were doing the work as opposed to writing lovely sort of stories about it. And I think there's a recognition now something needs to change in that, this whole way that academia is also constructed, because faith communities are actually doing stuff that no one else is recognising. So what do our faith communities offer? We know they offer, as you said very clearly, life values. We know that faith communities can offer literacy that transfers to health literacy. We know that faith has a capacity for an extraordinary global reach because, like Coca-Cola, which sounds terrible, we know there's faith communities in almost every village. Every society has numerous faith communities. That reach is extraordinary. That reach is now being recognised. But that reach hasn't just come about because of implementation and just leaving. That reach has come about because faith communities have stayed. Faith communities work together. Faith communities, in their inherent value of being with the people, of a message of Christ for and with people, are embedded. And last week we had a lecture from Professor Andrew Walls with a very strong message that, again, faith communities that have been built up by local people in their local language, believing and understanding the faith in the local context and contextualizing matters. But, and we do also have to recognize there is a history of stigma, rites and rituals that have been destructive. There's a history where systems have, religious systems, faith systems have, and particularly around HIV, where the church in the early days began to be very critical, very judgmental, very frightened of those who had HIV, seeing those who had as breaking religious taboos, Christian taboos. So we have to recognize that happening as well. But just giving you another snapshot of where things are happening. The German Federal Ministry for Economic Cooperation and Development have really led the way in saying now we need to understand where faith communities do offer, and the United Nations Interagency Task Force as well. So I want to just finish, or just have a couple more thoughts around the issues of values in our faith communities and how they mark towards development. But many of you are familiar with the marks of mission from the Anglican Consultative Council. And there was initially these 5 marks with 2 added on: the proclamation of the gospel, the nurture of believers, these loving acts of service, transforming unjust structures, and creation care, the care of the whole of creation, not just of the health of people, not just the health of animals, but the health of the land, the sea, the health of the air, and reconciliation and relational living. And if you unpick our 17 Sustainable Development Goals, you begin to see, actually, these marks of mission are almost, you can mirror them onto where the goals are trying to get. The nurture of believers, if we think, because what the goals are trying to say is we need to nurture humanity together. The loving acts of service, we need to, behind what we do, begin to believe that people have a value, and we are. And I just want to put up something from James Cochrane, who's done a huge amount of work looking at faith communities and their contribution to health in Africa. He's based in South Africa, but he's also talked quite a lot about why congregations, and congregations throughout the world, but congregations particularly through many African countries, have been so powerful in their ability to deliver to health, because they also deliver to the support networks. They provide the spiritual dimensions of health as well as the social dimensions, because congregations can accompany and convene, connect. And to story, congregations can provide a place where people can place their own narrative and the narrative of the past towards a narrative of the future. Congregations can give sanctuary, they can bless and pray and endure. And those things which are critical for a church community, those are the things that the health world is recognizing matter now. Those are the things that are going to change the way that non-communicable diseases are managed in community. Those are the things that are going to reduce the nihilism. Without those, we're lost. So I'm going to ask Mary, do you have any more time, or do you want me to, because I don't want to overgo another 5 minutes. Okay, because I put up a quotation here from William Fogg, who was who headed up the CDC, and he also was an extraordinary person. in the 80s and 90s, a missionary in Nigeria who really had with the smallpox eradication process in Nigeria, was a person who understood that the missions were the ones who actually knew what was happening in each village. So when he recognised there was outbreaks, and this was what didn't happen with Ebola. When he recognised there was outbreaks, he went and he connected to each missionary and said, send runners around your villages, tell me exactly who's got smallpox, what's happening, where is there any change? And he was able to collate a mapping, and then from that mapping put into the society a system of protection and care. But he also made this comment: is it not possible to dream of thousands of congregations working alongside public health, sharing and understanding that health is a seamless whole, physical, mental, social, spiritual, that poverty and illiteracy and addiction and prejudice and pollution and violence and hopelessness and fatalism are forms of brokenness, diseases that require deployment of both their assets in building whole community. And I think this is a wonderful statement, because really this is where we're at today. But this was made by someone who headed the CDC, the Center for Disease Control in the US, which was a major program of managing or looking at disease spread across the world. So I want to just finish with an illustration around palliative care, because one of the things that EMMS has done that's been so remarkable in their last few years is not just delivering and supporting palliative care. That's the care of those who are coming towards the ends of their lives, the care of those who are living with illnesses that aren't curable. But EMMS has recognised the power of integration, the power of ensuring that you work not just as islands of excellence, but you work in partnership with governments, with people, that the care is part of the community and not segregated from it. And for the universal health coverage, one particular catch is one of our Sustainable Development Goal targets in SDG 3. Universal health coverage means that everyone, every stage of their life, is able to access care that's not going to be financially ruining. And again, what EMMS has done around investing in palliative care is recognising that while lots of people are interested in investing in care for maternal and child health, for paediatrics, which is absolutely essential for disease prevention, many were forgetting that those coming towards the end of their life are also requiring care. So what does this look like in caring? Mary's seen this before. I always argue that a nation that looks after those who are born, who are most vulnerable, and who looks after those who are moving towards death, who are most vulnerable, who are least economically productive at those moments. A nation that does that is a nation that respects life for the value of life, not life as an economic product. And that is why palliative care is absolutely essential. Palliative care adds an enormous amount, and it's part of James's work, part of EMMS's work, to say palliative care because it provides the value base and the vocation that sits behind health. It says that people, regardless of what illness they have, and regardless of the fact they're not getting better, people themselves need to be cared for. And that care matters because that care is what we can do. Now, palliative care wasn't on the global health agenda at all until over the last few years, though, there's been a real push. And in 2014, a resolution was passed by the World Health Assembly, which identified the importance of palliative care. But this resolution really recognised that we needed to move to see that citizens should empower themselves to work towards equitable palliative care, what James is doing, and that palliative care invested and delivered properly would also would actually support the whole family, the whole community, the whole society. These are just a few quotations that, in a sense, just explain why palliative care matters and why the work that EMMS is doing matters. The quotations from work that I've done and work from different communities. And I think the power that lies in them, and in this first one, I'd like to go to sleep and wake up dead. That message from a woman who was dying of breast cancer, who had absolutely no pain relief at all. The pain was so severe. And that was what she said to me. I'd like to go to sleep and wake up dead. Because there was nothing she could do. She was chewing paracetamol, Panadol. There was nothing. We can, and EMMS has done enormous amounts to make big transitions. But I want you to look at this other quotation. I spent over £1 million shillings on care. This was in Uganda. Palliative care that's delivered properly also ensures that families are not spiraled into debt. And EMMS have really tried to identify that palliative care can also provide a mechanism for ensuring that communities can move forward. Because what was happening and what happens in so many places is children are taken out of school. No one, doctors and nurses are struggling to say this illness that you have is one that you're not going to get better, because no one wants to give that message, that effectively what feels like a curse, because it's a curse of death. No one gives it. So everyone stands back and said, well, maybe another hospital could provide something. Maybe if you go to a traditional healer, they could help. And people are spending more and more money selling the little they have, selling the goat or selling the sheep, selling the little bit of land, taking the children out of school because there's no school fees, for something that's not going to happen. The importance of really recognising and moving forward to support the work of palliative care globally is supporting the Sustainable Development Goals, but it's something that Christian communities have and are able to do, because Christian communities have at their heart a sense that we are together, that we instill a sense of hope before hope was lost in pain. Thank you.